I'm just sharing. So I pre-recorded this today in the interest of keeping to time. So.
Okay, we cannot hear it, so just give us a second. Can you pause it and I'll try and adjust?
Yeah.
So leave it on so that we know if I've got this fixed.
Okay, I can always just do it live if necessary, Gordana.
Yeah, it might just take a second. So if you put it on, and I will.
I'm just going to see if I can. You share.
Okay, we'll stop the sharing just for 1 second.
So while Rachel and Gordana just sort the technicalities, always a hazard of online webinars, isn't it? And you'll see that we've put in the chat box, I've put in the link for Lucy Delaney, the researcher at the University of Liverpool. So any of you that are interested in that, do feel free to get in touch with her. And Zara has also put in the links for you, both links to the NICE guideline, 95 I think it is, and also links to the Lyme disease toolkit. Definitely worth a look, because that has everything there that you need in bite-sized chunks, as it were. So I hope that you'll find these really useful to keep for later on.
So Rachel, would you mind trying to share again?
Okay, we'll try it one more time, and otherwise I'll revert to going live. So share screen.
I think you might have to give it live, Rachel, because I'll fix it, but it will take me a little bit of time now to fix.
Okay, that's fine. That's fine. I'm so sorry. I'm just going to restart then, and I'll access my slides without the voiceover, and I'll just be speedy. So
Thank you everyone for your patience. I've heard Rachel's talk before, and it's worth waiting for, I can tell you that, because it's an unusual take from both a patient and a doctor.
okay, so can you hear me, everybody? Can you hear me better now?
Yes,
can
that's
you hear me? Lovely. Okay, so I'm sorry about the technical hitches, and I'm going to sort of be as speedy as I can then. So I'm a GP, and in Somerset I've had personal and professional experience of Lyme disease. I have had Lyme disease twice, and also since that have been more aware and have seen a lot in clinical practice. And a bit of background, I have an interest in dermatology, which of course is relevant, and a long time ago did my degree in microbiology when I intercalated, and have been involved with lots of outdoor pursuits. And I really thought I knew about Lyme disease, and if anybody should have known, I should have known, and you'll see what I'm about to share with you, that I came unstuck really. So why raise awareness about Lyme disease? So GPs and other frontline clinicians, we are so critical to facilitate early diagnosis, and we are missing it. Diagnosis can be really challenging. There are hotspots, and it can occur anywhere in the UK. But my particular experience was that within just weeks, 4 of my immediate social circle contracted Lyme disease, and we had diverse presentations. And this little cluster of my friends just made me realise how what a clinical conundrum this was really, and quite how complex this illness was. And not just that, but my experience as a patient was truly harrowing, but doesn't even scratch the surface of the experience of some. And so I really felt a duty to sort of share my experience from both perspectives. And this is just a quick slide to sort of show there's a deer, but I live on the edge of woodland, and yes, we have deer, and what deer do is they increase the numbers of ticks in the environment because they're crucial to the mating cycle of the tick. So loads and loads of ticks if you've got deer, but deer don't harbour Borrelia. It's the little mice and the birds and the squirrels and other little vermin that just trap in and out of the woodland edge or the habitat transition. And I think that's why so many of my friends were affected, because we live in this habitat transition. And therefore I think if here, I think I would have a low threshold for prophylaxis because of that particular zone that we live in. And these are nymph ticks, and you can see from here how easy those would be to miss. I mean, they are the stage of the tick life cycle most likely to bite and transmit Lyme disease. And you can see this is why we are told to wear white trousers in the woods. You just wouldn't notice that unless you were looking for them. And this is my friend that I've already mentioned. So she happened to have a tick bite on the same day as me, and presented about a week later with fatigue and neck stiffness. As Anne mentioned, it's quite common to get neck stiffness. A few days after that, noticed this bullseye rash at the site where the tick had been, and she went to see the local her local GP surgery, and the clinician that she saw wasn't sure and sort of wanted to adopt a watch and wait approach and turned her away. And she was meanwhile getting more and more unwell, and it was her son who knew what she had and sent her back, because he was at the age of 15, he'd done his work experience in year 10 on the Mendips and had seen a poster. So that was rather harrowing that it was the 15-year-old that made the diagnosis. And this was somebody else in my woodland edge garden last year who went a couple of weeks after this gardening episode, went to the GP with this rash. Didn't tell me about it, but the key point I wanted to make was that this is a very obvious part of the body on the lower anterior shin. No tick had been noticed by this person at all. So she went to the GP and said, well, I know it's not Lyme disease because I haven't seen a tick. And that Anne talked about not being misled by our patients, and quite understandably and quite reasonably the GP did give a course of flucloxacillin, but the rash continued to spread, and at that point she mentioned it to me and we established this was Lyme disease, and thankfully she did respond to the Doxycycline for the 3 weeks. So this was a friend's son a few years ago who he had a really nasty bout of Lyme disease, ended up in A&E with sort of meningitis really, but he had a flu-like illness for 3 days, and then mum noticed this rash which then disappeared. She was an experienced nurse, and she clocked it and she took a picture. I don't think she realised the significance of it at the time, but my question at this point to you would be just to think, what if this child had long hair? So if this was a girl with long hair or a boy with long hair, would that have been noticed, and would there have been a delay? And it's important to make sure that we get people to tick check under hairlines in children. It's really common. So this is another child who presented with an insect bite behind the knee. Mum felt there had been something embedded in it, but and it looked infected, so quite reasonably the GP gave a course of flucloxacillin. But Mum was really convinced this was a tick, and the child was really getting more and more unwell, and Mum knew there was something not quite right. So she kept going back, and it took her 6 times and 6 visits to the GP to get the antibiotics for Lyme disease. But you can see that there's an evolving erythema migrans here, and it's about making sure that we're aware of a possible dual diagnosis here. I think this is something that catches us out a bit. So again, just to recap erythema migrans, because it's so important, is that it's a migrating redness. That's what it means. It can present anything from 3 days to 3 months after the tick bite, and although most are within 4 weeks or so. It can take longer, and it's so variable in appearance and behaviour, and it's not always a bullseye. And as Anne said, a third of people don't even have an EM rash. But what it is and I find this really helpful to remember, is that it's the immune reaction to the migrating spirochete that migrates out from the site of inoculation. And the immune reactions amongst individuals vary, and of course we're more aware of that now than we ever were, given the last 18 months and the COVID pandemic. So that is just something that's helpful that I remember. And again, just to reiterate, it can disseminate early. It's been isolated from the salivary glands of ticks. It can disseminate early. The early treatment is often effective, very often, and Borrelia isn't the only organism, so therefore we need to cover with doxycycline first line if we can. And this I find really helpful. I've got this printed on my wall in my GP surgery. It's the BMJ infographic, nice and colourful, and it gives you the schedule of doses, and it's quite easy to reference and access. So I've got that certainly in the summer. So I've got a case initially of one of my patients who I saw. Well, she initially presented to the emergency department when she had been playing in the woods, became a bit unwell. A few days later, and mum noticed a rash. They didn't remember a tick bite, a tick attached at all. It's just that there was this rash, and fever, headache, tired, tummy ache. Amazingly and brilliantly, the ED clinician diagnosed erythema migrans and prescribed amoxicillin for 21 days and advised to see the GP in 3 weeks, which was all very good. But 3 weeks later, she was still unwell. She was only just managing school, fatigued, really hot and sweaty in the evenings, really poorly. Mum was worried. And so at that point, I thought, oh my goodness, what's going on? And I asked Mum to check the dose that she'd been given, because there was no dose on the discharge summary. And she'd been taking 5 mils of the 250 milligram syrup 3 times a day, so just a quarter of what she should have been having. And there was no other explanation for her significant symptoms, and so realised at that point that she has had partially or sort of insufficiently or untreated Lyme disease. And so actually, according to the guidance, doxycycline is first line in a child of that age, so we commenced doxycycline. And I did refer to a paediatrician, but 1 week later, she was even worse. She was sleeping all the time. At that point, she couldn't get out of bed, and I was getting really quite worried about her. But I spoke at that point. I actually phoned the paediatrician, and we discussed this, and we agreed this was almost certainly a gerish Herxheimer reaction. And because of my concern about the delay already, we agreed to use amoxicillin and full dose doxycycline together to avoid the delay, and she made a brilliant recovery, which was just wonderful to see. And in sort of treatment of Lyme disease, it always brings me back to the wisdom of William Osler, who was in first year of medical school. I remember being quite inspired by him and the quotes that he put forward, and the clinical acumen and the that he had to display pre-testing. And I have sort of patients where that's with Lyme disease that I've had to take that approach, and they've got better, and it's not following testing or and I think where there are uncertainties, so it's going back to first principles. And so my story, why tell it? So I think my concern from the very beginning that I had a really atypical presentation with negative serology, even at quite a late stage. And if I was not a doctor patient, I wouldn't have known what I had. If I hadn't connected the tick bite to my symptoms, I would not have known what this was. If I hadn't known I had a tick bite, I wouldn't have clocked it. And if I'd have had a patient come to see me who hadn't raised tick bite, I don't think I'd have made the diagnosis either. And that really concerned me, because I obviously may well have become really much more unwell had I not got it as early as I did. And even as a doctor patient with late disseminated illness, my experience was quite harrowing, and it taught me a lot about doctor patient interaction and about, well, I'll share it a bit more here. So I had a tick bite knew all about it. The photo was just on the previous slide, and it lived in my freezer for about a year after that. The tick was there probably for less than 16 hours, and I removed it really safely. I thought I'd be fine. I really thought it was low risk, and I did check for an EM rash for the 4 weeks or so, nothing obvious, and I forgot all about it. Absolutely fine, I was well. Until about 7 weeks later, when I was in my afternoon surgery and my lips started to twitch. I noticed I had to bite my lip to stop my lip quivering. I remember thinking, I wonder if the patients are noticing what I'm doing. I wonder if they can see my twitching. And then over the next 3 days, I got progressive twitching periorally of my calves, of my hands, and I began to develop insomnia, which is really unusual for me. I never had a problem with sleep, and also some tongue numbness and some right-sided facial numbness. And it was all rather concerning. But after about 3 days, I had a light bulb moment, and I remembered the tick bite, and I managed to connect the two and realized I had neurological sort of sequelae of Lyme disease, and that this was now early disseminated. It was all sort of progressing by the day. And when my daughter took a picture of my back where I'd had the tick bite, there was then a very faint EM rash. And there it is. You can see just about the punctum just in the top right of the little the triangular sort of shape, and the edge at the bottom. But this was about 8 weeks after the original tick bite. It's faint. You can barely see it. It's small. It wasn't anything like my friend's leg, who had this horrendously, this awful rash, and so clearly my immune reaction was very different to hers. I did have a widespread rash visible after a shower, and I did start doxycycline, and my symptoms definitely attenuated. They didn't go completely, but they attenuated. And then after that 4 weeks, within days of stopping, I started to get a relapse with novel symptoms, and I got new chest pain, new twitches, palpitations, more neurological symptoms that seemed to be progressing sort of proximally. And so I had another course of doxycycline, and again, all settled down. It seemed really antibiotic responsive, and I had other sort of symptoms that were suggestive of a more significant illness. And I was beginning to get a bit tired at that point, and it felt to me like a very, very active process. I wasn't expecting not to get better after that first 4 weeks, so it was disconcerting to still have those symptoms. And I asked for a referral, which my GP thankfully did. I knew I had disseminated disease, and I started to read an awful lot. And I was struck at that point. So although I had an EM rash at 8 weeks, my GP did do a serology, which technically wasn't necessary because I had a clinical diagnosis, but I'm really glad she did, because it was negative even at that stage. And then when I did end up in the infectious disease clinic, it was negative again at 14 weeks. And that, although I had antibiotics at that stage, but that really raised to me how I knew I had Lyme disease. I had an EM rash at the site of the tip. There's absolutely no question about the diagnosis, but my tests were negative. And I think this was something that really needed to be talked about, because I saw how people were being dismissed with negative tests. And when I subsequently did have a test done privately, there were some faintly positive bands, which I do think would have been dismissed as a false positive had it been done. But I knew that what this was, and it raised lots of questions for me, because I presented late, had a very faint erythema migrans. I was clearly unwell enough to lose weight and lose hair, but no antibody test. Why was I still having ongoing symptoms? And I read about this, and I came across this very excellent review article. Oh, this is a more recent review article actually, but I read and discovered that the biology of Borrelia as an organism is incredible. It's one of the most complex bacteria known to man. It's a master of disguises. It's designed to persist, as you know about the life cycle in the mice. It targets immune privileged sites. It both evades and suppresses the immune system, and that made me think, goodness, in me, with my particular genetic profile or whatever, with a particular strain, has it suppressed my immunity such that I'm not raising a response to it. It's very clever if it's doing that, but that's why I'm not raising a response. That's why I'm testing negative, and I think that's got huge clinical significance for patients potentially, and I don't think that is talked about enough. So it does cause hugely variable disease. We know about these 3 different strains that all present slightly differently clinically. So Guerini is more neurological. Bergdorferi is more of an arthritis picture, although there is crossover. And of course, co-infections complicate the picture. And knowing about this, I mean, what would you have done if this was you? If you had symptoms that were antibiotic responsive, that were not settling, and then as soon as you stop the antibiotics, you get worse again, and you feel it's very active. What would you do? And what do other doctors do when they get Lyme disease? And I certainly wasn't the first doctor to go and seek private treatment and have that, sort of elsewhere outside the NHS, and that's got massive implications for our patients too. So from a patient perspective, that evidence is lacking. People get really poorly, all of this, that people get better with other treatments, whether that's herbalist treatments or prolonged antibiotics in some cases. Lots of things people do report getting better, and it's not just a few people, it's big numbers. And so one takes that seriously when one has this illness. And I know that absence of evidence is not evidence that it doesn't work, lack of research, disagreement amongst medical professionals. And I very much sensed that in my appointments with my clinicians, I've had it twice, that there just wasn't enough time to engage with them. It was very clear that the clinicians that I saw, they were time pressured. They thought I was anxious. They just didn't know what I was going on. They didn't understand why I was so concerned about it, and I didn't feel heard, and I did feel quite belittled, even as a doctor. And I've only just really begun to be able to name what this was, but there is a phenomenon called medical gaslighting, and it's something that I think we could all fall into the trap of, even on a subconscious level because of our training. And it's something that I certainly would want to be very, very aware of. And I know that this happens. It definitely happened to me. I've seen it happen to others. And especially with a disease like Lyme disease, which is so poorly understood. So I felt dismissed, questioned and scrutinised. I perceived that there was a lack of curiosity, probably because of the time pressure, and that there was a lack of willingness to discuss the uncertainties. My clinicians really thought, well, they seemed very certain that I was going to be fine, when what I was reading suggested that maybe that wouldn't be the case if I and they said things like, we don't know what your symptoms are, but we know they're not serious, and you're just anxious, you'll be fine, and these symptoms might not even be Lyme disease, and I want you to show me a photo of your rash and send it to my secretary, as if they didn't believe me, even though I'm a clinical assistant in dermatology. So it did feel quite challenging and difficult, and I felt really disempowered even as a doctor. And I was informed in no uncertain terms that antibiotics are not a treatment for neuropathy, and I thought, well, I'm not silly, I know that, but I was just explaining that my symptoms were very, very responsive to antibiotic treatment, but I was said, absolutely, you've had more than enough treatment, you'll be fine, off you go now. And it felt quite difficult. So gaslighting is a form of manipulation when someone's made to question their sanity, perception, reality, or memories. And it's common in intimate relationships in the context of emotionally abusive partner relationships, but also in social interactions where there's an imbalance of power. And of course, in the doctor-patient relationship, sadly, there sometimes is an imbalance of power, much as we try to mitigate that. And with our modern training, I think we do a lot of the time, but but there's no denying that still happens, especially within the constraints of a consultation that's time pressured, when you have a huge pressure and a backlog of patients to see, and sometimes people with very unreasonable expectations and demands. I think sometimes this is a trap we can, as I say, fall into as doctors, but actually a person on the receiving end of this behaviour is experiencing abuse essentially, and that this is a really harrowing concept really for me. And the techniques that happen within gaslighting, I think I experienced all of them in my medical consultation. So countering, sort of questioning the history in a negative way, sort of quite disparaging. Are you sure that happened? I mean, how do you know? And then withholding, sort of refusing to engage in dialogue, partly because of time pressure. I mean, sometimes we just have to do that as doctors. Trivializing and you know, belittling experiences, thinking, oh, you're just anxious, you know, or maybe it's just stress, or changing the focus of discussion, or stereotyping. So they said, well, lots of doctors, when they get these twitches, think they've got motor neurone disease, you know, they're there, you'll be all right. Or, you know, women of your age, you know, often have sort of non-specific symptoms like this, and it's menopause, or, you know, that sort of attitude. So it was, like I say, quite disempowering, even though these were clearly good doctors who excellent at their, you know, in their roles. But I found it very sad, really, to come away feeling the way I did. And as a doctor, as I say, I think we do know that this is very difficult, very easy for us to fall into the trap, and very difficult when you've got challenging patient with unexplained symptoms. But I think sometimes symptoms are medically unexplained simply because we haven't got the diagnosis right, and we do have to be aware that trauma can cause some of these symptoms, and there is certainly psychosomatic illness, but I think that can sometimes be used as a blanket, and sometimes we need to think, is there anything else going on? And I think Lyme disease is one of those classic things where you could label a patient as having psychiatric symptoms, and actually they are, you know, they're actually suffering with an untreated disease. So, you know, what often happens is they told post-treatment Lyme, and that's it. And we expect them to improve, or they then refer, or a doctor may refer to another specialty, and these people end up going through specialty after specialty on a quest for an answer that never comes. And my combined doctor-patient view is that these patients are potentially lost to follow-up, because perceiving that they've hit a brick wall and that they're not being listened to, they often do seek treatment outside the NHS, and many do report good outcomes, but these outcomes are not being captured, positive or negative, and that has huge implications, and we are missing catching them, we're missing keeping them safe, we're missing learning what is actually working, because they are just dismissed from clinics, I think, and then they go elsewhere and nobody ever knows what happens to them. Assume they get better perhaps, but they don't always. So more research is urgently needed, and we as doctors really need to collaborate with our colleagues in all the specialties and in other disciplines to share information and the management of these sort of complex patients. So I think it's all about talking, it's all about transparency and humility and science, looking at the research, what's it really telling us, without any of us having sort of an agenda. And I think the solution would be a specialist clinic, with multi-specialty and multidisciplinary collaboration, with open discussion and long-term follow-up of patients and development of clinical expertise that way, and of course research, because there are still uncertainties. Thank you. So I'm